I suspect they would do it.
Well, she's a pediatric nurse and she keeps getting reinfected. Well, that sort of,
Good.
that's why you keep getting infected.
Yeah.
But anyway,
Well, if you send me an email reminder, I can forward it to our lab medicine guy. Yeah.
it'd be nice to get a news test on her so there wasn't any question of timing, because her old one is like 3 years ago. And then her new one was crap. And then she has the old one IVIG. But she doesn't want to get sick anyway. So it's anyway, so I thought I'd present that to you and find out who to talk to. But it sounds like I'll just send it to you. And she sees Drew at clinic in Bellevue, so she can get blood there.
Yeah, we could. Is that possible? I don't remember. Absolutely. This is for a while, so. And yeah, I mean, frankly, we don't even need to run it.
All right, I don't know how many of you outside in your pajamas day off, but we got a decent turnout today. There was only one speaker that I could invite who has Robert win the Super Bowl and stage.
Which was worse, the State of the Union or the Super Bowl?
So I don't know. Anyway, so John has been doing this for us for a number of years and always updates us on the most interesting things in his specialty. So thanks to everybody for bringing the ice up. He's from the East Coast. No one would consider this any significant inconvenience at all. Paralyzes the city. So John, thanks for coming.
Thanks for having me. It's always a pleasure to come and visit with this group every year. As I walked in here, I get a specific question I'm going to try to address as we go through this. Thanks for braving the ice. It is only, though, in Seattle that someone would drive their bike in. So East Coast, it would just drive in and it was work, but here, people actually ride their bikes. Congrats, man.
Oh, just Matt.
I have no disclosures. A few years ago, I started listing the topics I started covering because I never get to the last one. And so in 2016, I talked about Zika, stewardship in the Allergist, the cure for C. difficile. Then last year, I talked about Zika, influenza, Ebola virus updates, little dice media, challenge stewardship, and C. diff, which I never got to. Then a brief perspective on infectious disease ecology last year. Talked about Candida auris, this very drug-resistant candida that popped up simultaneously all over the planet around the same time. And then talked about C. difficile. And then I never got to drug-resistant bacteria. So today I'm going to talk about drug resistance, because this is sort of a theme that I've meant to touch on over the last several years, but never have gotten there. I'm going to start with a little bit of a quick ID update and a question about vaccines. So when we last spoke, I was talking about fish and making them live longer by giving them microbiotic transplants. But I'm going to shift gears. If you guys remember that last year, that's where I sort of stopped. It was a really cool study showing you could make fish live longer by giving them the transplants from a younger fish. It's still pretty cool stuff. So the stuff around microbiota is still going on. But I'm not going to talk about that today. So today, measles update is the first thing we're going to lead off with. So this is just from yesterday. I think everyone in this room hopefully knows there's a measles outbreak going on in Clark County Center around Vancouver, Washington. As of last night or the night before, 47 confirmed cases, 7 suspected cases, so somewhere in the low 50s or mid 50s. With the vast majority of those cases being young kids, so 34 and ages 1 through 10, 12 cases 11 through 18, 1 case 11 through 29, 1 adult in King County. Since this started, there's also been a family that went to Hawaii that quarantined during their entire vacation. There's a couple folks who went to Oregon, as far as I know, no additional cases from that. And then there's down here some folks who confirmed cases who also moved from Clark County to Georgia. So it's really important to recognize when these outbreaks happen, even though it doesn't feel like a huge one, I mean, almost 50 people, they move around quite quickly and can lead to transmissions elsewhere very easily. The other thing I'll point out here, and this is probably the crux of today's discussion, is that 41 of these cases are unimmunized, 5 of them are unverified. There is one person who's got a vaccine who's got 1 case, but I don't know more details about that. Only one person's been in the hospital so far. So briefly, again, because I was asked to just touch base on this as I walked in around vaccination. So the measles, mumps, rubella vaccine is the vaccine we use to prevent measles. it is highly effective. So the general strategy is for vaccination is in children. So your first vaccine around 1 year of age, and your second vaccine around 4 to 6 years of age. You can get it as soon as 4 weeks after that first vaccine, and there are people out there who talk about alternative or slow vaccine schedules. It's already pretty slow. If you get it at 1 year of age and you get the next one 3 years later, there's not really, that's a pretty long time, or 4 years later, or 5 years later. It's totally fine, and that's a normal pediatric schedule. You can get it as early as 6 months of age, but then you have to get onto the normal vaccine schedule. So if you're a child who's flying to measles endemic country where there's happening outbreaks, you can get vaccinated at 6 months of age, but then you have to get on the normal schedule starting at 1 year of age. The measles, mumps, rubella vaccine is very effective but has varying efficacy for the different viruses. So rubella is quite good. Mumps, variable. As we've seen with outbreaks here in Washington State, the majority of people who get mumps were vaccinated, but probably don't have a lot of the bad outcomes. We don't see the bad things that happen from mumps happening in that outbreak. But the measles part of the vaccine is actually very, very effective. And so the way it works is the first vaccine captures probably 93, 94% of individuals. So if you're a year-old baby vaccinated within 2 to 4 weeks, 93 or so % of those kids are fully immune. The second vaccine at 4 years of age is to get kind of another 3 to 5% of those kids and get us to 97, 98% of vaccinated people being immunized. So it doesn't give you it's not a booster. It's meant to just capture the kids who didn't respond to the first one. But ultimately, you end up having 2 to 3% of people, even with a perfect vaccine schedule, are not covered. And it's really, again, interesting to think about when we think about this idea of herd immunity. Is thrown out. So for instance, influenza, we really want to see 85% of the population vaccinated. That's going to be very effective against preventing transmission within populations. With measles, we're talking about an extremely, if not the most communicable virus out there. So if you take a room full of 10 people, none of whom have any immunity, you put someone with measles into that room in close proximity, 9 out of 10 of those people theoretically be infected. So it's what they call the R0 is something probably in the 15 to 18 range. It just means that for every one person, an unvaccinated person, an unvaccinated population, they will be transmitting to somewhere around 15 to 20 people every time. So it's an extremely transmissible disease. The vast majority of people who get measles develop a fever, then a cough, runny nose, runny eyes, all of which are full of virus and obviously easy to spread. And that's in the absence of a rash. It's not until about 4 days after those symptoms arise that you start developing the rash. And you're contagious from 4 days prior to 4 days after. So you can see in that non-rash, thinking about a part of the infection during the flu season, you look like you got a cough, you got a fever, you got a runny nose, and you're actually transmitting measles around. And you could look like many other respiratory diseases. So that's what most people develop, and it resolves usually a week or so after the rash. But a subset of kids, particularly children, some adults, older folks, people who have been compromised, develop complications, which can range from pneumonia and otitis media and diarrhea, again, like a lot of other things, to more life-threatening CNS infections. You can see someone's already ended up in the hospital. That was early on. There was only about 30 or less cases. It can have to be quite complicated. And obviously, things like measles, CNS infection, one of the leading causes of deafness and other persistent CNS diseases in the past. The last huge outbreak in the United States was in 1989 to 1991. It was a series of outbreaks that infected about 55,000, mostly poor urban children who didn't have access to a good vaccine program. And in that outbreak, 100 people died. So, it's not a small number. But that was recognized, there was a good response, legislation was passed, and funds were made available to make sure that all children have access in the United States to vaccination programs. And in 2000, the United States declared the United States measles was eliminated, which means we don't have any endemic measles spread. The pattern of measles in the United States is that folks come from countries where it is endemic, they fly in, right, and they land in an unvaccinated population. So we don't know this one, but if you look in 2018, there were people in that county. There's been other outbreaks in that area, flying in from places in Europe, Eastern Europe, where there's now a very large outbreak going on in Ukraine with hundreds and hundreds and hundreds of people flying in. And so I suspect it's something like that. They haven't identified that exact thing, but we know that's how it happens. In Seattle, in the summer of last year, we had someone flying from South Asia, developed a rash in flight. He was coming from a place where we know measles was circulating in an outbreak, got a rash, got in an Uber, took it to Harborview ER, was sitting in our ER for about 30 to 45 minutes. He had a mask, unfortunately, and was hospitalized and determined to have measles. So it can happen anytime, any place, very easily. Again, he took pictures of his rash as he was coming over. It was like just moving down his face. You know, it's a long flight from where he was. He, fortunately, we had no secondary infections. And that's because the measles vaccine is very, very good. And in a healthcare setting, for most adults, most of them are vaccinated. So going back to that point of the protective effects of sort of the herd immunity of the vaccine, what's different about the measles vaccine versus influenza, where you need like 85% of folks covered? In measles, you really need everyone covered. You need like 98, 99% of people vaccinated, because if you do have an exposure event, likelihood of transmission is extremely high, right? And then the more people get infected, the more likely there's going to be complications. Right now in the United States, we have this outbreak going on. There's actually a large outbreak going on in New York, New York City, and New Jersey among an Orthodox Jewish population who are under or not vaccinated. Historically, though, there's been these pockets of unvaccinated individuals, and it's interesting, again, going back to the discussion that was asked, just to touch base on, is that the reasons that people don't get vaccinated in the United States are very heterogeneous. It is the craziest, craziest, like, I should say crazy. Oh, thank you. Something that's like frost. It's frost. My glasses.
Delayed frost.
Yeah, exactly. Delayed frost. Delayed onset frost. The reasons are all over the place. I shouldn't say crazy because I'm actually more sympathetic than that. But it's one of these really, I say crazy in that it's this Venn diagram of wildly different reasons, from don't tell me what to do, to the vaccine is dangerous, to lack of trust, to I eat healthy, it's not going to happen to me, the measles isn't dangerous, and it's this thing where people from many socioeconomic, educational backgrounds, religious backgrounds, all overlap, where you get people from the far left and the far right coming together and saying, we're not getting vaccinated for reasons that really don't make a lot of sense. The one thing I will say is that, we haven't found the language, and I think my pediatric colleagues have done a lot more in this, like scientifically, and trying to figure out how to get people, parents specifically, over their vaccine hesitancy. But it is a difficult thing, and it's not, no one message is going to fix it. I do come from the perspective that parents are worried about their children, right? You want to keep their kids safe, and so we need to address that. But there's been misinformation. In these days of false news and false science and all these accusations, we have to be careful how we throw those terms around. But the problem with the measles vaccine is that there's been published science that has been since retracted. So the biggest study came out in the Lancet a number of years ago by a scientist there. I don't even like to say his name, but because he's such a terrible person. But he published this paper linking autism to MMR vaccine. It was subsequently found that study was discredited, the data was not good, he had conflicts of interest, the paper was retracted and canceled. He actually ended up losing his license in the UK and left. Basically excommunicated from the physician and scientist community in the UK. Came to the United States and has actually set up a very nice career here preying on people. And this is the one place where I will be clear, I am sympathetic about parents, and I do want to recognize that we need to find better language to help them. But he has found a willing audience of folks here that he preys upon. And it's really awful because it is the whole spectrum of people from hyper-educated, Clark County parents who should know better and have the background and means, to the really at-risk communities like the Somali community in Minneapolis, Minnesota, who have less access to healthcare, have less access to work, have less access to education. He's gone to them and talked to them and say that these vaccines are going to kill you and sort of lead to bad effects in your children. That's led to outbreaks in the Somali community. So when we think about measles in the United States, that type of activity, I would say that person is, and people who speak in that way are responsible for the death and sickness of children and adults in the United States. And so that's a really problematic area that I can't find any sympathy for. But the parents' perspective when they hear this is something that needs to be addressed. And again, I don't have good answers for it, but you have to sit down and recognize the benefits of this vaccine, the effectiveness of the vaccine. Again, the measles vaccine is extremely effective. If you're vaccinated, you're almost certainly not going to get infected. And the bad outcomes of having measles. So we'll see where this goes. If anyone's had good experience around talking to parents, that feel free to share it with the audience. But the one thing I will say that has been effective for me with adults, and it's rare, but it's worked, unlike almost everything else I've had, is that the only reason people can say, I don't want to be vaccinated, is because everyone around them is vaccinated. And so the issue is there, and this is where it might sound a little harsher, but you don't have the freedom to not get vaccinated for any reason unless everyone around you is vaccinated. If you think that this is fine not to be vaccinated, then go spend some time in Somalia or Sudan or rural Philippines or parts of Cambodia or the Ukraine with your kid right now. The reasons that you probably wouldn't do that are why you should get vaccinated in the United States. We keep kids safe, and parents and adults and immunocompromised people and older folks safe here in the United States because everyone is vaccinated. And so that freedom to not vaccinate is directly related to everyone else stepping up and taking the action of getting vaccinated. And when I sort of help people recognize that they say, oh, there's a risk, I'm like, well, they're taking the risk, but you're not, but you're benefiting. They maybe start to understand that there's a shared communal reason to get vaccinated that goes beyond their ultimately somewhat selfish perspective.
Was there ever a time when it was mandatory? It seems to me when I was a kid, there was no one ever said no. You didn't, I don't know.
Well, when you were a kid, measles was circulating, right? Mumps was circulating, rubella was circulating, varicella zoster. Many of those things were causing pregnancy loss and deaths in kids. I say the one thing that we could do is you can't mandate vaccination, but you can mandate who can go to school. And that's the key thing. And so in Washington State right now, there's actually a bipartisan bill that's being put on for vote that would, between Democrat and Republican, that would mandate measles, mumps, rubella, and other vaccines before coming to school, public school.
Are there states where that is law?
There's actually, I think it's like 13 or 15 states where that's law. I mean, in states you wouldn't, like Louisiana, like states that tend to have more conservative or more libertarian. So it is effective. It works fine. So I think hopefully that'll work.
So what are your statistics that you share about the adverse effects of the vaccine? I mean, I know that's another topic all by itself, but I read the death rate is still 0.2% for measles if you naturally acquire it, which is 1,000-fold higher than any side effect you can find.
Right.
What do you tell people in terms of side effects?
I'm not a pediatrician, so I don't give the vaccine that often. So it is a live bacterial or attenuated viral vaccine. So there are groups we can't give it to, right? We can't give it to immunocompromised folks who are counting on us to get vaccinated. We can't give it to pregnant women. So there is a very, very small risk that you can have a sort of pseudomeasles infection. But again, it would be an attenuated viral infection, so not a persistent one, probably not transmitting. No vaccine is without risk, but the risks, as you pointed out, are extremely small. And there's zero, and there's randomized controlled trials showing that it's safe and has no link to autism or other neurocognitive problems. Just the last illustration, because I'm probably going on too long about this, but it's super interesting, is that there was, I think you guys remember last summer, there was a media program out there that a nurse in Texas, an ER nurse, who didn't believe in vaccinations, what they call themselves anti-vaxxers or whatever they call, who was an ER nurse and had a baby with measles in her ER. And the baby was suffering. Baby went to the critical care unit. And the mom, the nurse, took a picture of the baby and posted on Facebook and saying, oh, look at this baby suffering. I've never seen measles before. But what was really interesting is that she said, I haven't changed my stance. I actually thought about bringing my teenager in to get exposed, so natural immunity. And she got fired because you're not supposed to put pictures of your patients on Facebook. But she did not change her stance, despite having a baby in her ER who was suffering and went to the ICU. So again, just thinking about the barriers, like we haven't found the right language to talk to people who see a child suffering with a disease, yet desire not to prevent it. So it is a challenge. And again, my pediatric colleagues are probably way ahead of me on this. I'm not a pediatrician. But it is, it's really challenging. I don't have a good answer for all of it.
I'll quit bugging you.
You're not bugging me. It's really important. Any questions about measles? Again, I get to talk whatever I want up here, so yeah, that's the best thing about giving this lecture every year is I do whatever I want. Okay, well that's 20 minutes on that, so I'm probably not going to get to antibiotic resistance again. I always keep do 3 things. I just want to let you guys know that the Ebola outbreak, so I've talked to you in the past about Ebola, but just as update as of last week, there's a total 730 cases with more than half of them who have died. This is a really concerning outbreak. It is limited to the Democratic Republic of Congo. It started in August of last year, so this is burning on and on and on. The issue here is if you're familiar with DRC, it's actually covered up by this thing over here, but the DRC is obviously a huge country, right, going from the Atlantic over to Uganda, and this is really over right against the Ugandan border. So it's a really small part of the country, but you can see it's spread in a lot of parts here, right along the border. The Ugandans are very, very concerned about this, and it's probably been where more of the U.S. activity has been. We have no one from the U.S. in this area because of political violence and civil unrest, and that's a big difference in this outbreak compared to the prior outbreak, is that there's a war going on here, right, and all kinds of conflict, which makes it quite dangerous for healthcare workers to be present. There's a lot of distrust of the medical system there, and so a lot of folks are being, infected at home, getting sick at home, dying at home, and only being found out later. There are vaccination programs, which is probably what's kept it somewhat limited, but there's, again, that distrust part, going back to our conversation on measles, there's a lot of distrust around teams of people coming out, providing health care, pulling people out of their communities into these Ebola treatment centers, and vaccinating them. Right, so vaccine hesitancy, concern is a global phenomenon. We know this again, like in polio. Not able to get rid of polio because of that same problem. So we'll keep updated there. One of the biggest issues here is just occasional entry into these very large cities. So we got into a recent 1 million-person city, and that's where we're really worried about, like an ignition event, where you get into a poor part of an urban area and you start spreading wildly in those places. But again, you can't see it out here. It's on your slides, but this is in the very, very far eastern part of the DRC, so far from the ports, really limited to the border with Uganda. And so we'll see how it goes.
What is the status of the Ebola vaccine?
So it's being deployed here. It appears to be effective. I don't have vaccine effectiveness numbers off the top of my head. I should look those up last night. But it seems to be pretty useful, pretty effective, and it's being used wildly here.
And is this the same vaccine that came out?
Came out of this program there, yeah. There were several that came out. I'm not sure which of these is which, but I think there's several potential vaccines, and this is the one that's being used. There has been one person transported to the United States, so for instance, our public health touched base with us, our review whether we're prepared to receive someone. We have people from Seattle and Washington State working in this area, so we'll see what happens.
Is it an attenuated vaccine or is it a dead vaccine?
I believe it's a dead. Yeah. No one wants attenuated Ebola. I'm not 100% sure.
Just checking.
Yeah, I have to look it up again. It's been a while since I looked at this.
The one the NIH had developed was it was a peptide.
But, so we'll see. It's very scary. Okay, so I'm going to talk about drug resistance. Is that okay? Switching gears. So we talked about antibiotics. We talked about viruses. So, have I ever told this? You guys ever told you this really quickly? Okay, so this is a kid named David Ricci. He's been on PBS, and he's got me on 60 Minutes and so forth. He's a kid I took care of a number of years ago. So, he was 20 years old, went to work in India, an AIDS orphanage, sort of kind of a gap year or post-college thing, and was walking along a train track in an urban area, and along train tracks, there's lots of people use these as thoroughfares, right, in many parts of it, including India. and trains come through, and they may not always go fast, but they're going through. They're big and they're not going to slow down for you. And it came by and hooked his coat, and it pulled him under the train, and took off most of his right leg. They put him in the back of a cart, brought him to the nearest hospital. They amputated his leg, kind of mid-thigh, put a bunch of drains in, moved to another hospital. His wound just wouldn't stop draining. They went in and washed it out, kept draining it, had a bunch of drains in it. So his parents flew out there, picked him up, put him on a plane, brought him to SeaTac, sort of like our measles phase last year, and just drove him to Hartford. And he was admitted to our step-down burn unit, where we put a lot of people with large wounds, and was there 3 days when one of my orthopedic colleagues, who specializes in amputations, Doug Smith, called me and said, "John, you probably already know about this, but what's your plan for, you guys thinking about this?" So I looked up the kid, brought this up, and I said, "Doug, I want you to go to his room, and I don't want you to let anyone in or out. I'll be there in like 5 minutes." And I was there probably 2. And he had been in India. This was in like 2011. These are 2 of like 5 different bacteria that grew out of this draining wound from his leg. And for those of you who don't do this a lot, we have 2 different bacteria, Pseudomonas aeruginosa, E. coli. One's an Antibacteriaceae, one's not an Antibacteriaceae. So sort of 2 big groups of gram-negative rods. This is the antibiotic susceptibility chart with all the antimicrobials here on this side, and the R stands for resistant. Not too hard to figure out. The I is intermediate, which I, as an infectious disease doctor, kind of think of as resistant too. We just use that in the United States. I'll point out here that both of these, I don't have it up here, that the last-ditch antibiotic we talked about is colistin. This is kind of detergent we put into people's veins when we see these sorts of things. And the resistance, the MICs for both of these were 2 or above, which means you really can't get that level of colistin in simple state. So basically, pan-resistant bacteria come out of his leg. So this is 2011. You've been to India. I was like, I'm very worried. I know what this is. This isn't just bad resistance. These are bacteria that may harbor a gene that was described in 2009 called the New Delhi beta-lactamase. Again, we're not going to talk about genetics and so forth, but this beta-lactamase is a carbapenemase. It conveys resistance to almost all beta-lactams. And it tends, when you see this gene, the bacteria that have the gene tend to run with a bunch of other bad genetic mechanisms, big pumps and porins and all that sort of stuff. So the bacteria tend to be resistant to aminoglycosides for quinolones, antimicrobials. Some resistant to last-ditch drugs like tigecycline and colistin. At this point, have been described in Klebs, E. coli, Citrobacter cereuli, Antibacteriaceae. And again, by the time we'd seen this in Seattle, this particular gene had been described in a number of countries around the world after being initially described in New Delhi. I put in contact precautions. He was 3 feet away from another patient with a large burn wound. And we had seen this happen, 15 years ago, where he got transmission in our hospital, leads to a number of infections. So I was very nervous and worried about it, but fortunately we had no secondary transmissions. We sent these off to the CDC and to Scott Weissman's lab at Seattle Children's, and indeed, he had the first described NDM1-containing infection here in Washington State. And so the point isn't to go to NDM1 or any of these types of things, but the point is that, like measles and like many other things, it takes no time at all for people with infectious diseases, for many different types, to move around the planet and to pop up into emergency departments or long-term care facilities or rehab facilities or ORs anywhere in the world, including Seattle or anywhere else in the state. So what I wanted to look like is change sort of the perspective around antibiotic resistance and start thinking about it as an emerging infectious disease. So we think about emerging infectious diseases sort of like Ebola or SARS or sort of these new pathogens, ones we've maybe never seen before. But when you actually look at what defines an emerging infectious disease, it can be something like a new organism, SARS, MERS, things we never heard about. Evolution of organisms that become more pathogenic or so forth, moving to new areas. So for instance, West Nile, that we knew that existed. It was in the Middle East, but when it introduced in the United States, it became an emerging pathogen, then moved across the United States. Breakdown of public health, certainly. So resurgent measles can be considered emerging infection here in the United States. But new drug resistance, so the ability of an organism to become drug resistant, also puts into that category of emerging infectious disease. And when we think about emerging infectious disease, I think we give it a certain gravitas, a certain weight that we don't think of when we just say, oh, it's drug resistant, right? This is right now, hopefully by the end of this talk, you'll recognize this is a global public health threat. So what are the major concerns for resistance? There's a lot. I'm not going to talk about each of these, but just so you put it in your head and again sort of contextualize it. Back in the day, a long time ago, we used to be able to use chloroquine for falciparum malaria. You know, pretty tolerable drug, pretty cheap. That's almost, you can't use that almost anywhere in the world except sort of the Caribbean area. MTB, all the gains we've made in tuberculosis deaths are threatened to be eclipsed by multi-drug resistant tuberculosis. Gonorrhea, we sort of, gonorrhea, STD, what have you. This is actually becoming one of the biggest drug resistant threats out there. Every single antibiotic we've ever used for gonorrhea, gonorrhea is developed a resistance to. Every single one. And when you think about the morbidity of gonorrhea, easily transmitted, often unknown, right? And can lead to significant morbidity, particularly in women and undetected infections. So you can get problems around, pelvic inflammatory disease, you can get infertility. That woman could be infected, in her 20s, try to have a child in their 30s, and it doesn't happen because of prior infection, and maybe even occult infection. So when you think about drug resistance, the ability, and the way we treat folks, is we think of just a few pills. That's not the case anymore. So you think about people who are at risk for gonorrhea and the access to healthcare. If you can give them, treat them once when they're in front of you with pills, right? Those days are going away. Now it's a shot in pills. What happens when they're both shots? What happens when they're IV medication? What happens with multi-day regimens? The likelihood of actually adherence becomes lower and lower, and the risk for drug resistance goes up and up and up. So this is a big deal. Now, what I just talked about, the big issue is gram-negative rods, which is, I think, a lot of the attention is right now. Influenza resistance, we've seen also some of the resistance. We've seen it up here at UWC and other places in the world, and HIV is kind of the prototypical. Basic resistance constantly. Basically, there's a whole drug industry based around the fact that HIV develops resistance to everything all the time. So when you think about all those things, again, contextualizing drug resistance, this has been recognized at a very high level. So antibiotics and the susceptibility of bacteria to antibiotics in the world is a basis for medicine. We cannot do rituximab. We can't do, you were just mentioned earlier, we can't do surgery. We can't do safe C-sections. We can't do chemotherapy. We can't do, solid organ transplants without antibiotics, because all of those things require, prophylaxis and the effective utility of antibiotics. So when you go to get your ankle replaced, right, you get a shot of cefazolin, because the last thing that can happen, if that ankle gets infected, right, that's hardware, that's metal, that's going to be a big problem.
You're done.
The metal can't come out for a long time, disability, I've seen this a lot. All those things are possible because of antibiotics. So if we don't have, those antibiotics aren't effective, and again, I'm not trying to be inflammatory or nihilistic or whatever, but just fact-based. If we don't have antibiotics to do these things, that's a security threat, right? It's a threat to how we practice medicine at its base. Just think about C-sections. Millions of C-sections, they only can be really safely done if you can give prophylactic antibiotics. So this is recognized at a high level. So this is a report from the CDC on antibiotic resistance threats in the United States, published in 2013. There's a whole bunch of things on there. It's actually a really nice document. You can see urgent threats, receipt of the seal, carbapenem-resistant enterobacteriaceae, E. coli I showed you before, in drug-resistant Neisseria gonorrhea for the reasons I sort of outlined. So those are the urgent threats. Serious threats, you can see a big, long list of them there, ranging from things like Shigella and Salmonella. I'll just point out we have a drug-resistant Shigella outbreak in Seattle that was basically undetected until recently. Things like MRSA, drug-resistant strep pneumo, the number one cause of otitis media, bacterial otitis media, bacterial rhinosinusitis, pneumonia, meningitis, TB, and then concerning threats down here. We have clindamycin-resistant group-A strep here in Western Washington. So we have many of these things right here. This has led to a lot of other things. So when the CDC published this, the Obama White House published the National Strategy for Combating Antibiotic-Resistant Bacteria, September 2014. And in 2016, I think this is only the fourth high-level meeting ever conducted by the United Nations and the WHO, and it was on antibiotic resistance. So in the whole history of the UN, they only had 4 of these. And one of them was on antibiotics. So just to give you a sense of how serious people are starting to take this as a security threat. There's been lots of talk about this. So, deadly drug-resistant superbugs pose a huge threat, WHO says.
And then some stuff like this. This comes out of some UK papers. The post-antibiotic era is here. Antibiotic resistance can spell the end of modern medicine. We're on the verge of a post-antibiotic era. No, not quite there. But that's the concern. And so when the public's looking at this, when national security people are looking at this, when sort of global health people are looking at this is sort of the concern, right? You start talking about the concern before they actually happen, so you can do something about it. So, and again, are we there yet? No, but that kid I took care of when he was 20 took 3 more surgeries, almost lost the rest of his leg. Took me 6 months, but with renal failure once, lost 20 pounds, dropped his white count to 0 once. And finally, my last course of antibiotics were 4 drugs I put him on and kept all going until he couldn't tolerate each one of them. Tigecycline, colistin, mirapen, rifampin. Basically, when he just would barf too much, I stopped tigecycline. Cell counts would go down, I stopped the mirapen, and so forth, and just cross my fingers. And it was a long course. And imagine if that sort of thing complicates your normal course, like that's the standard. And in parts of the world, that is. Neonatal ICUs in some parts of urban India, that NDM1 containing organisms are the predominant genes you find for drug resistance in many places. Big problem. And, I talk about,
And all those kids die in India?
No. I think that they are getting them, kidneys are pretty healthy. They can take a lot, glycosides and colistin, and they get better at it, but a lot of them do die. And these are neonates, like neonatal ICU patients. Yeah, I think outcomes are very poor. And just to illustrate that, like this is just one study from a while ago, but this is carbapenem-resistant Klebsiella pneumonia carbapenemase. This is carbapenem-sensitive Klebsiella pneumonia carbapenemase. You look at overall mortality versus cumulative mortality. This is percentage of subjects who die. So you want to be blue or red? If you're going to have a Klebsiella pneumonia, this is not political. If you want to have one of these infections, which of these buckets do you want to be in, right? You want to have the sensitive one. And this study's been done over and over and over again. The data's quite good. Okay, so again, coming back to sort of the global perspective, this is looking at the costs of antibiotic resistance, and I bring this up for just a couple of reasons. One is where we have data, and this is a little bit older, this goes back a few years, 2014, but it's a nice illustration. Look at European Union, so, industrialized countries, industrialized country, 25,000 deaths, a lot of extra hospital days, a lot of millions of illnesses. Societal costs, 900 million in hospital days, approximately 1.5 billion euros per year. Here, 20 to 35 billion per year. But what's really important here is that low and middle income countries are actually disproportionately being hit with this. So this isn't a rich country problem. This is a global country problem. This is every country in the world. You go to Pakistan, you go to Thailand, you go to Ukraine, you go to the UK, you go to Greece, you go to Spain, you go to rural Kenya, where we're doing some work on this. You're going to see this problem. And just look at this, 38,000 deaths. So this is Thailand, 70 million people, 300 million, 500, right? 38,000 deaths, 3 million extra hospital days. And, looking at 84 to 202 million in direct costs, greater than 1.3 billion. So when you think about a low income or middle income country like Thailand, and you put this drag, this anchor on its system, right? That's a significant problem. This, Thailand's ready to launch to get into the fully industrialized, era. But you throw in, we're going to just take away $1.3 billion of your money, is a problem. So again, big deal. Okay, and this continues to happen. So I talked about the NDM1. You guys heard about the article. Anybody recognize it?
It looks familiar.
Yeah, that's right. So, again, the problem is this continues to accelerate. So this came, it was a paper published in 2015. It was in 15. So more recently, after the SARS epidemic, the Chinese public health really stepped up and really started publishing a lot of stuff that they were finding. And what they described was they started to see colistin resistance happening in their agriculture sector, so in animals. They started seeing just more and more colistin resistance. So let's go and look at our pool of isolates from pigs and cows across eastern China. And what they described was the first, I mentioned that colistin is our last-ditch drug. They described the first colistin resistance mediated by a gene. They call that MCR1. There's now been MCR1 through at least 3, maybe 4. And this conveys resistance to colistin. So our last stage drug, finally out. And what's interesting, in China, they use colistin by the tonnage in animals, but not in humans. In the United States, we use colistin in humans, but not in animals. So it's interesting how these things are changed. So they found in animal meat, and when they went back, they said, well, let's just check. And they pulled human samples from patients, and they found MCR1 circulating in humans as well. And what's really fascinating is that in Europe, they said, oh, you know, let's just start doing surveillance for this. And they pulled banks of their samples and actually found samples in Denmark as well that had MCR1. So the point is, the bacteria can develop resistance to almost anything, really anything. They can do it with genetic mechanisms. Appears to be linked to agriculture to some extent for some things. But that's not totally clear. And it can happen underneath your nose, right? If you're not looking for it, you will not see it until it's too late. And so the Europeans had it there already. And I'll show you they're not alone in that. So when you think about colistin, and you think about other drug resistance mechanisms, say you have an NDM, right? And then you have colistin in there, you basically you develop like the superbug of all superbugs. You don't just have like a phenotypic resistance. You have a genotypic mechanism to resist everything. It basically makes it functionally impossible to treat. And this was soon followed up in 2016 with the discovery of an E. coli bacteria containing MCR1 in the United States. This is in Philadelphia, a woman who had never traveled, as far as we know, and she was only picked up because the U.S. Army had opened up a new base, a new lab in that area, just do basic surveillance, and her urine got sent in, was found to have MCR in it. Resistant to colistin. Now, it was sensitive to the other treatment, so it was fine, but would never have known if it wasn't for this fortuitous opening of this lab nearby to do the surveillance. But this has gone on to cause other problems. This is a case, again, soon after, a woman who died from a superbug, from an MCR-containing Klebsiella pneumoniae. And I think she had been overseas and came back and had this infection. And it started in her urine, JUTI, which was untreatable. They tested 26 different antibiotics resistant to all of them. She died from that. So pretty challenging. So I went back, and I did this last year, but what I wanted to show you was where these things are happening right now. So this is first reported in 2016 from Pennsylvania. But the last year, I think this is the list that was there. And as of this year, this is the list. I think I have everything on there. Did I get everything on there? Yeah, I did. So you can see all the places where MCR1 has been reported in the United States now, many, many states. And I'll just bring you down here to Washington. So you see May 2018, but also point out May 2008. You guys remember? You're not supposed to remember, but just a quick quiz. When was the publication for this? 2015? 14, 15? I thought it was in December 14. And there's one from 2008. So this is really interesting is that we bank a lot of drug-resistant bacteria here in Washington State in different places, research, public health, and so forth. And a research group working with public health, like CDC, got access to genetic material, I think on the East Coast someplace. They did the study, and published results. It didn't actually end up telling us that they actually found MCR containing bacteria in Washington from 2008 samples. In Washington. They didn't tell us until we saw the publication. So, again, these things are around and you don't even know it. They circulate quietly until they are detected. And again, we didn't even know that existed in 2008. So really, really interesting. And this is the big concern. So MCR by itself, just conveying colistin resistance, I don't use colistin for treating ETIs and all this other stuff because I have other antibiotics I can use. The problem that we're really concerned about is you take the MCR1 gene or the MCR2 or 3, you put it into something else. And these bacteria are circulating widely. They're very promiscuous. Gram-negative rods trade genetic material all the time between not only within species and strains, but outside of species. We know that. In that kid, David, we saw bacteria that didn't have MDM1, so Morganella did not have MDM1, and subsequently, 2 months down the road, his Morganella isolates did have MDM1, probably from gene swapping within his gut. And this is what we're concerned about. So MCR1, colistin resistant, in an extended spectrum beta-lactamase producing Klebsiella pneumoniae in France. leading to a big outbreak in an ICU. These are, I think, mostly vented patients. You can see that here's the resistance genes in these. These are, so you have no more ceftriaxone, maybe no cefepime, all the beta-lactams outside of carbapenems, no colistin. You're really getting very, very limited in terms of your access to drugs. So it's this confluence of drug resistance mechanisms and epidemics that are coming together and feeding off each other and making the epidemic just worse and worse and worse. So that's one big epidemic, and I'd say the mortality rate in this was nearly 100%. Here's another one, a fatal outbreak of a carbapenem-resistant hypervirulent Klebsiella pneumonia. So there's some bad Kleb pneumo in Asia. And this is carbapenem resistance, same thing as MDM1, carbapenem resistance, linking together with other genetic mechanisms for resistance. And these are all ventilated patients. I don't know if you guys can read it, but they've got 21 carbapenem resistant strains from patients, characterized these all, had these hypervirulent strains. And I'm trying to find, the death rate was, I think, you see it right there, it's extremely high. I'm spacing out right now. Sorry, I linked here. Killed 100%. Oh, that's not. But anyway, I think it was 90+% mortality rate. So again, you start losing these ability to effectively treat something that happens fairly often, so pneumonia in the ICU. And even kind of what, again, thinking about acceleration, I'm not going to go into this mechanism because it comes in the same outbreak. But when you go to places like this and you look in their water output, so as an infectious disease and infection prevention doctor, I think about where water's coming in, where water's going out, air handling and so forth, the architecture of a hospital. And this is the part that actually probably scares me amongst the most, is that if you look at the water outflow from hospitals, and now this isn't, I'm just picking on China, this is just where the study came from, but you can find these genes in the outflow of the water. So you can find MCR1 and other carbapenemases in hospital sewage in Beijing, China, come from the hospitals themselves. So these hospitals are concentrating these things and then spewing it out. You can go into the urban areas of New Delhi or other places like that, Kolkata in India, and sample water on the side of the street. You can find MCR1 or NDM1, sorry, not MCR1, but NDM1 in the water because of lack of controlled sanitation in these places, and many other places. So, yeah.
So usually, the question is, what drives the emergence of these? Normally, we think overuse of antibiotics.
Yeah.
But is this just spontaneous? I guess is the answer.
Well, I don't know if I have the answer, but
But
I'm trying.
Posing the question.
Yeah, so it's a lot of things. So there's these data thrown out there. I only have about 12 minutes or so. You guys hanging in there? Yeah. Okay. So there's these data out there, at least among inpatients, about half the antibiotics we give inpatient are inappropriate. It's a rough estimate. And we know that when you give these inappropriate antibiotics, you increase C. diff rates, you increase adverse events, increase costs, but it also drives drug resistance. What I want to say is that 100% of antibiotics do these things. Even if you use antibiotics perfectly, only appropriately, we're going to link that antibiotic use to things like C. diff, adverse events, costs, but also drug resistance. So, yeah, if we can get rid of half it, will we slow things down? Definitely. But if we use antibiotics, we will generate resistance, period, even if we use it perfectly. And getting to why, so there's a lot of reasons why we have drug resistance, but one thing I'd like to make sure people understand is that drug resistance has been with us forever, right? Bacteria and fungi have been fighting a battle for billions of years. We are latecomers to this game. This is a really cool study published a few years ago in Science. There's another one in Nature that's very similar. And you know those core samples they do, the climate scientists do in the Arctic and so forth, in Antarctica? So this is a similar thing, but they do tundra samples. So they go up to, in this case, they go up here on Dawson City outside of Yukon, and they go to these places and they put down these steel plates, they put alcohol over the plates, make sure they don't spoil it, and they do core samples down through the tundra. And they went down, you can see they go down here all these millions of years, and they're down here around 30,000 years. So the time of giant ducks and giant rabbits and bison and wild mammoths and stuff like that, they were able to isolate genes from bacteria. And they described in this paper two genes, VAN A and VAN B, which are the genes that convey vancomycin resistance and enterococci. So VRE, a common problem in UWMC and in highly immunocompromised populations we followed here. So drug-resistant bacteria, the genes for that were found 35,000 years ago, and I guarantee you, none of us are using vancomycin. I can be absolutely sure about that. And the issue is that things that we are seeing are things that the bacteria and fungi have already been figuring out, right? Most of our antibiotics come from classes developed within fungi, right? Other natural sources. And they're just exploiting kind of all different variations on it. But those are all things that the bacteria and fungi have already developed to fight each other, and feed off each other, and kill each other, and defend each other from other attacks. So a lot of this stuff is just selection. If we're going to use antibiotics at all, we are going to select for drug resistance of some types. Now, some are mutants and coming up, but a lot of this is just figuring out. If you actually look at the MCR1 story, it's actually probably a lot more complicated because you can probably find it in some sort of estuary bacteria because there's a colistin sort of correlate in the natural world that bacteria have already had to fight against. And so if you go out and look in Vibrio species, like non-pathogenic Vibrio species in sort of estuary water in Washington State, you can find MCR1 in some of those bacteria. So the point is that they have been fighting. They've already sort of figured this out. Again, we're late comers to it. We're just providing the selection, and we're sort of the most recent filter for detecting. So you take that sort of scenario, and then you look at antibiotic utilization around the world. So this is looking at macrolide antibiotic use in developing countries. The United States is on this far right. You can see it's going down in Sweden. But in other countries in the world, it's going back a little bit, but it's going up and up and up. And this is another conundrum around antimicrobial use, is that the vast majority of under 5 tests in the world die without antibiotics. But they need them. So the problem is, this isn't like getting rid of polio or getting rid of measles, right? This is, we need antibiotics sometimes, and we don't need antibiotics other times. And so this isn't eliminating antibiotic use. This is maximizing the appropriate use of antibiotic use to extend the timeline, to extend the horizon to the emergence of drug resistance, which is arguably, my perspective, inevitable. Right? We want to maximize the use of each antimicrobial for as long as possible. So that's macrolide. So it's something that we want to see that happen, right? This is looking at carbapenem antibiotics to treat gram-negatives in different places. So here's Netherlands, pretty flat. USA, pretty flat. You look at former West Africa, India, Pakistan. So huge spikes in carbapenem use. And this is a little bit crazy because in some, again, why are people using carbapenems? Well, they're extremely effective. They cover everything. But is it because of drug resistance that's driving this? Is it inappropriate pharmaceutical sales? In some parts of the world, like Indian Pakistan, you can buy drugs over the counter without a prescription. And that's the person's livelihood, right? That's how a pharmacist feeds their family and makes their living, is selling these medications. You can get oral carbapenems in India now. I can't get those, but you can. So it's really interesting. But let's take it back to the United States. This is a map published again a few years ago looking at national antibiotic use at a glance. So just briefly, this is looking at antibiotic prescriptions per 1,000 people. So Alaska is the state in the United States with the lowest, 533 antibiotic prescriptions per year per 1,000 people. West Virginia is the highest, 1,214 antibiotic prescriptions per 1,000 people per year. So I'll say just two things about this. One, why is there variation? I mean, it should be pretty close. And, in bacterial infections happening probably pretty similarly in this part of the world, or as in this part of the country. It's not like, everyone here is vaccinated, that's for sure. And so, why is this different? I mean, more like half. And two, why are 1 out of every 2 people get an antibiotic prescription on average in Alaska? I mean, even where it's low, it's high. Obviously this is concentrating in kids and repeat prescriptions, but 1.2 prescriptions per person, antibiotics per year in this area, on average. And the problem is when you start looking at these antibiotic uses, they talk about this variation. This is a cool graphic looking at countries. So this is European industrialized countries, with France being up here, Spain, the Netherlands down here. This is looking at outpatient use of penicillins on this axis. So going this direction, you're seeing more antibiotic use by tonnage, penicillin, in these countries. And you look at penicillin-resistant strep pneumo, again, the most common bacterial cause of meningitis, otitis media, and pneumonia globally. There seems to be a pretty clear association between how many tons of penicillin you use in your country and how much drug-resistant bacteria you have in your country.
Does that split out agricultural use and animals? It's just total?
Yeah, just humans. And we're right, the United States is not on this graphic, but we fall in here when you look at comparisons. So we're right in the middle. But it seems pretty compelling. I don't know. And when you talk at the patient level, this is a nice graphic looking at a whole series of studies looking at the receipt of antibiotics and the detection of drug-resistant bacteria within individual patients. So that was the one I showed you was country level. This is individual patients, a whole host of them. Looking at 101 months out to 12 months. Looking at the odds ratio of having a drug-resistant pathogen after the receipt of antibiotics. And you can see that every one of these studies, until you get further and further out, supports the notion that if you give someone an antibiotic, the likelihood of that person being colonized or infected with the drug-resistant bacteria goes up. So the patient in front of you. This is one thing about physicians. We're prescribing. Our job is to take care of the patients in front of you. Now, we also think about the population, but I think we need to start thinking harder about that. Not only population, but thinking harder about the patient in front of us, because we may actually be causing more harm than good for many of these occasions. And a lot of the times, we're giving antibiotics for no good reason. This is a nice randomized controlled study with a lot of people, 1,000 people, 12 countries, looking at adults with acute lower respiratory tract infection without suspicion of pneumonia. I won't go into the details of all of this, but they basically randomized folks to antibiotics versus no antibiotics, so amoxicillin versus placebo, and looked at resolution over time. You can see that the curves overlap perfectly, right? So giving amoxicillin has been shown to not be helpful in lower respiratory tract infection without evidence of pneumonia. But we do it all the time. I pulled every antibiotic prescription from UW Medicine. I know every single antibiotic prescription every single month by everybody. And the number one reason we give antibiotics is cough, right? And upper respiratory tract infections and cough. I mean, it's all variations on URI by far. It's mostly azithromycin. And this has been paying attention to. So we look at the state level. This is the Washington Health Alliance, which is a group of big companies in the state which are looking at healthcare costs and other things. This is from their health waste calculator, and looking at 735,000 individuals who receive antibiotics for rhinosinusitis or acute otitis, external otitis. I think that must be otitis media, excuse me. I don't know why they wrote that. Cost $2.3 million, but in their analysis, 98% of these individuals who receive antibiotics were given them unnecessarily. So these are the people who are paying the bills. This is the companies who are doing this analysis, and they have a whole waste calculator on this. So this is antibiotics for acute upper respiratory tract infections, ear infections. And I'll just say, so they're saying 97.7% of this is a waste. This red part's a waste. Let's just say they're wrong by half. That's 50% of the antibiotics are wrong, are inappropriate. So again, we have data, but we're still doing this. And that's a challenge. I'm just going to skip the point of this for just timing. This is looking at people in the VA system giving antibiotics there and some of the reasons. So again, going back to post-surgical stuff, these are all in patients who had C. difficile infection, so at-risk patients. And you look at the reasons why we gave these antibiotics. Slow healing of a flap, no fever, no drainage, no evidence of infection, got antibiotics. Clearly documented asymptomatic bacteria. Got CDI, recurrent CDI, and died. Positive sputum culture, no fever, no respiratory symptoms, no evidence of clinical infection documented. Asymptomatic pyruvate bacteria while hospitalized, got CDI. Maybe an infiltrate, but no fever, no respiratory symptoms, got CDI. Mild rosacea, get antibiotics. Now, these are inpatients who had C. diff, so at-risk people. And you see the confusing documentation here, and what ends up happening is that we hit the easy button, what we think is the easy button, and give people antibiotics, even when they're at risk for bad outcome. Okay. A couple more minutes. Hopefully I end on a high note here. So this is also being accelerated by technology. Do you guys know what this is?
Endoscope.
Yeah, it's an ERCP. So this is a scope. It's an endoscopic retrograde cholangiopancreatography scope. And the issue here is that technology is really challenging. So these are important, right? If you have cancer affecting your bile duct system and you have to get a stent or something else, do you want this or do you want surgery? I want this, right? Because you're going to be fragile, chemotherapy, slow healing, all the complications. You just want to feel better. But this, I'll just argue, is impossible to clean. You cannot sterilize these as electronics, and they're very hard to clean. The most important part here is elbow grease, literally. Someone knows what they're doing, how to start with. Even then, we know if you check them, you'll find stuff. And the point is, you take patients who have colonization of drug resistance in their gut, and then you throw technology like this in there, and things can move around like they did at VM. And a lot of it we don't know about until we know about it. So just a point here, I'm going to close out just this last bit because you asked about it. We actually are right at the end. Jeez, I do this every time. It's because you had to ask about measles. I just really pick up on this, but what I'll talk about next year, is how this is accelerated by agriculture to some extent, but again, it's more complicated. We cannot point the fingers at our colleagues in the animal world because it's going both directions, and we're as responsible for it as they are. And there's stuff that are being done to deal with this, I think, but it's not the answer. So removing all antibiotics from animals isn't going to fix this. But again, we'll pick this up 1 year from now. That's okay. We have more slides there to look at.
Maybe we should bring it back twice a year.
Yeah, twice a year. 2 parts. Well, if you can tolerate that.
Is the kid infecting the pig, or is the pig infecting the kid?
That's a very good question. I mean, which one's the vector here?
Actually, this picture, I think, was about reducing atopic disease by kids being contacted with animals early in life.
Yeah.
The hygiene hypothesis.
Yeah.
Not a.
I know that my dog's microbiota and my youngest daughter's microbiota are essentially the same. Their breath is about the same. Their effluent is about the same.
I'm curious, I mean, because this sounds like an intractable problem, yet the UN had that meeting.
Yeah.
Did they give tangible recommendations at the end of it as to what to do?
A lot of political posturing, so I think the idea is to bring attention and to recognize that, like, what's happening in India. India, when that was published, that New Delhi paper, they were very, very, very unhappy. And the lead author on there, or the senior author on the paper, was banned from India. We stopped calling things. I think it was actually, that was like the last one where we stopped calling things after where they're found, right? So we do. That's why MCR1 is not, Beijing glycerin resistance. And the Indian government, actually, give them credit, has really tried very hard to rein in unrestricted antimicrobial use. But you have this thing where, like, well, that's how this person makes their living, right? And millions of people making their living that way, and their kids and so forth. So how do you pull that in? Well, I think that they're trying to get it back there. I think there's been a lot. So the thing I'll skip ahead. This is all really cool, but to some extent, the Global Health Security Agenda is linked to this. So what I would argue is, do I need to get out? You okay? What I think has come out of that over the years is in part this. So this is the Global Health Security Agenda, which is really a multi-sector investment process to empower things like surveillance for lots of things, so big outbreaks, vaccination programs, but I would say really importantly, and writing here is small, is infection control and what they call AMR. So when they say AMR, it's what I often call stewardship, but so it's the response to the problem. But the way we're going to handle this is using antibiotics appropriately, doing good surveillance and getting a handle on it, but preventing transmission. And where we're going to prevent transmission for the most part is going to be in hospitals and healthcare. And if you go, so I work on a project in Kenya at 2 hospitals. We're implementing infection prevention education, and they're doing QI projects around surgical site infections, safe syringe handling, and this goes on, how we handle waste and hand hygiene. And I would argue that a lot of this funding that's now coming into place now, and it's going on to 2025, I think, the most recent update, is what's happening as a result of that attention. So it takes a decade or so to get things rolling. And more and more attention like this just came out from the NHS, looking at this estimate of 10 million deaths by 2050. Estimated to come out of drug resistance, like 1 every 3 seconds or something. And so I think it's more attention. I think you see this global funding, sort of like you saw with Gavi or something like that, focused on empowering hospitals and healthcare sites and governments to pay attention to drug resistance as a serious threat. And I'll tell you, it is. You go to rural Kenya where we're doing this work, and we're seeing stuff in these places that do not have the drugs. They treat these infections. So it's a real serious issue for everyone. Again, I'm not trying to blow this up, but I think just reframing it as this isn't just we need to do better with antibiotics. This is an issue that we need to address. It's basically my concern or my position. Okay, that's it.
Thank you.
attention.
Why is it tripping this now?
You guys are always so nice. Thank you.
We always have more topics. I know you've got stuff to say.
Oh yeah, I know where to start. Let's talk about animals.
More interested in the people around the country. And I mostly just wanted to ask you, even though you don't have to,
Getting any better
are you still studying that? Or
Every time you talk about that kid from Harborview, he's from Snohomish, and his church sponsored bringing him back.
Oh, did it?
And they raised a bunch of money and they tried to talk me into it.
Oh,
And they told me
have
that.
I talked about
I'm
it?
a Santa Fe.
Sure. Sorry.
No, it's a great case.
Yeah.
I mean, and then I said, like, why don't you do this? I
Well,
don't
that's
have
scientific.
And it ended up the sense where they took it because
Is he in the
actually,
I mean, at the very least, having great I'll take care of you.
I know I always set you up with the medical document, but
I was able to save it.
maybe we can set out the time.
any of these things, I mean, they look, obviously they're looking at their drugs.
Yeah, I mean, half the population who have interest.
I think the hottest thing I think in that area, so
brand new.
I'll be
But yeah, it's coming up in other places in the
the thing
country,
that
and I
I've seen
think you're
probably
the
the
one
most
that
pressing
came up with the whole concept, right? Well, you're the only person I've seen.
basically, yeah, getting a custom back virus.
Okay, right, I'll send you an email.
So you can get, I mean, if you go by pages, you get only staff works, right? And so that's pretty close to, you know, it doesn't kill anything else, has no bacteria. In fact, the challenge is with nobody else, and
Probably in rehab,
right?
twice pressure on.
Right, so now you're gonna,
And I need that one.
yeah, I don't know how, like, what's the price?
Anyway, it was okay.
Over and over and over again.
Oh, I see.
But at least you can, yeah, she used it, so I think in Europe, that's, still being used, these days. And I think people are starting to,
No, I don't know why.
that may be really
Just this go and everybody's sitting at home.
I don't know, like, this isn't much. No, it's funny too, like, I mean, we've been, all been
Unless there's some magic.
every day, you know?
Yeah.
Because yesterday, they said, are you not I said, what, what's going on? I
Put out there, really
I
very.
keep taking like a 10-minute break, you know.
The new tetracycline. Is that gonna solve this problem?
Right, if you have doxy resistance, then you already have some level of resistance.
Okay, do you want to come over
Anyway, it's just
earlier?
cool to hear.
I'm staying here, like I'm saying Sunday area, so I can come in here, I'm available.
Good luck with the vaccine talk. Just gentle, constant pressure. Relax. Just no reality check.
There's no faculty.
Well,
That job.
You know, let you know that I was at my career doctor and I have for like, it's not, this is not a medical question, it's just a comment.
Yeah.
She offered me azithromycin.
Thank you, Taha.
Everything, and I turned it down, because I don't want it, but I isn't Z-Pack
Yeah,
the
Z-Pack.
reason that is what killed sensitivity.
Well, I mean, azithromycin is by far the most prescribed topical
Yeah,
in the
it's
country.
amazing.
And it's given for coughs all the time. You know, the issue is that it has an anti-inflammatory.
Thank you.
Right.
Oh, you're welcome.
See you
Thanks
next
for
week.
inviting me. Yeah, definitely.
But like, is it still sensitive?
You know, it
I mean, it's
varies.
nothing against my doctor, but
Yeah, no.
just last night.
I mean, most people, I mean, the chronic cough is not due to bacteria, so it's not so much a resistance issue, it's just not, yeah, it may have some anti-inflammatory, but so does. And so, and it has downsides too, right? You get into toxicity and really no benefits. So, yeah, but in terms of resistance, yeah, I mean, there's
I was just
rising.
wondering what the sensitivity patterns are for azithromycin.
Well, it depends. So it depends on which bacteria. So,
It's
like,
still, so it's still sensitive.
yeah. So I mean, start new one still works, I think,
Okay.
in general. But I hope someone forget their journals.
Anyway, that was a great talk.
Oh, thank you.
I like that.
Another one of these. Yeah, it's great. These guys are great. I just talk about whatever I want every single year. They seem to listen, so.
Actually, it looks great.